Hello, and welcome. We look forward to being able to speak with you today. Name of our presentation is Aim to Learn, Actioning on Implicit Biases and Microaggressions in the Learning Environment. Myself and my two other colleagues today will be presenting this presentation. And so we're going to go ahead and start to do some introductions. Before our introductions, I want to mention that we have no disclosures to report as part of this presentation. My name is Ashley Hubbard, and I'm currently the Director of the Office of Diversity, Equity, and Inclusion at the San Francisco VA Medical Center, and I'm an Assistant Clinical Professor at the University of California, San Francisco.
My name is Caitlin Hasser, and I am a psychiatrist at the Portland VA healthcare system. And I recently transitioned from working at the San Francisco VA and UCSF.
Hi everyone, my name is William Hua. I'm a staff psychologist at the San Francisco VA healthcare system and also an associate clinical professor at the University of California, San Francisco.
So today we are going to be covering a number of different areas, and these are our objectives for the entire course, including today's talk and the 2-hour interactive portion of the course. So we hope by the end of this time together that you will be able to identify ways that implicit bias and microaggressions can impact our perceptions and behaviors in patient care and the clinical learning environment. Describe how identity, including both personal and professional identities, and intersectionality impact team dynamics. Practice communication strategies to use when faced with unexpected bias. And for today, we are going to be covering these areas where we'll be talking initially about how to foster an inclusive learning environment, and then going into a little bit more depth about bias, microaggressions, intersectionality, and wrapping up with some recommendations. So when we think about this topic, one of the things that is important is remembering that there's no single story. The single story is often told by those who are in power as a definitive story about a group of people. And this quote really captures the limitations of that idea. And we're really doing this work to expand beyond a single story or stereotype, to have a balance of stories and humility about the breadth of experiences that we, our patients, and our learners have. I assume that many of you are educators working with trainees on clinical rotations. And something that's, very important is creating an equitable learning environment that can provide all students with the opportunities to learn and to demonstrate their learning and to be able to succeed. And we know that students from racial and ethnic groups that are underrepresented in medicine face inequities because they must simultaneously confront pressures that all medical students and all health profession trainees must encounter, like improving their patient care skills, improving medical knowledge, adapting to new clinical settings and environments, working with different teams, trying to figure out the hidden curriculum of, what's accepted and what's not, what are some of the spoken and unspoken expectations. And then there are also specific pressures that people who are underrepresented in medicine must navigate that can disproportionately and negatively impact performance. And these include things such as supervisor bias, microaggressions from patients and staff, and encountering stereotype threat. So I'd like you to take a moment to reflect on a situation where you noticed a concern involving a learner related to diversity, equity, or inclusion. This could be a situation where you were the learner, or you were an educator, or you were a team member who was observing this. And just hold this example in your mind as we move forward to review some definitions. So wanted to be sure we're all on the same page in terms of what different things mean. So I just want to kind of quickly go over some definitions, and we'll be revisiting each of these in a bit more depth. So the first is explicit bias. This is stereotypes, attitudes, and impressions about people or a group of people that you're actively aware of. This is something that is conscious. In contrast to implicit bias, which is unconscious, unintentional, or automatic mental processes in which individuals may hold negative beliefs about others. And, implicit biases are often related to messages we've gotten, from culture, might be blind spots that we hold and might not coincide with our explicitly held beliefs. The next definition is microaggressions. So these are brief and common daily verbal, behavioral, or environmental indignities that can be intentional or unintentional. So this is another key point, and that communicate hostile, derogatory, or negative messages to or about historically stigmatized groups. So some key points in this are that, what someone is intending may or may not be the same thing as where it lands. And it might also be directed specifically towards a group or individual, or it might be about a group or individual. And just also wanted to say, even though the word micro is in there, these often do not feel very micro when they occur. And the next are stereotype threat, which is this idea that people, when people find themselves in a situation where they are or feel themselves to be at risk of conforming to a stereotype about their social group, and it causes increased stress and threat. And then intersectionality, which is identities that interact with one another to shape our sense of self and how we interact with the world. And so we will be, again, reviewing each of these in more depth later in the presentation, starting with stereotype threat. So this, again, is a psychological phenomenon in which members of a negatively stereotyped group worry that they will conform to those stereotypes. And that fear can impair performance. So even subtle context-dependent cues around race and ethnicity can trigger stereotype threat and impair performance. And it really depends on sort of what is the stereotype about that group and what is the context that we're talking about. And there have been a number of studies looking at this. It's been implicated in the underperformance of women in mathematics, African American and Latinx students on tests of individual ability, elderly undergoing cognitive tests. And another example is when told they would be compared with Asian men, white men underperformed on a math exam. So again, this relates to what is primed and then what the specific context is that's related to a stereotype. And, impairment from stereotype threat arises as awareness of the stereotype threat influences the person and in the context of learning, the learner's affective, cognitive, and motivational states. And we end up seeing reduced performance, reduced communication, decreased sense of belonging, reduced interest, reduced effort because of this kind of self-fulfilling prophecy of I'm not expected to do well anyway. And then these ultimately lead to reduced workplace diversity and then perpetuation of stereotypes because of this reduced performance that can end up occurring. So it's a very vicious cycle. And, one of the ways performance is impacted by limiting cognitive resources through these mechanisms here: disruption of working memory and executive function, increased arousal, self-consciousness and performance monitoring, right? What am I doing right now, and all this cognitive load that's going to evaluating everything that's happening in the circumstances. And then because of the activation of negative thoughts and emotion, there's a lot of effort to suppress that, particularly in evaluative settings. So we have several studies that demonstrate the impact of stereotype threat in medical training specifically. The first here shows that if students had a perception of stereotype threat, it activated negative emotions in both African American and first generation students. Other studies have showed higher rates of specific racial and ethnic stereotype threat in groups that are underrepresented in medicine during core clerkships, and that this was greater for students of specific backgrounds and correlated with fewer honors grades. And you can see in a recent study, about a third of respondents had a high vulnerability to stereotype threat, and there was a lot of variation depending on background. So to create more equitable learning environments, it's important to understand the factors which disproportionately affect some students. So a recent qualitative study attempted to characterize what is really going on with stereotype threat during clinical rotations. So I'm sure many of you have students who come and rotate for their core psychiatry clerkship on CL rotations. And so this would capture some of the experience of some of your students. So this was a study that involved fourth-year medical students at 2 institutions, and was involved purposive interviews with a sample of respondents. So a few things that came out of what triggered stereotype threat. So one was the concept of standing out. So students described from the beginning of the clerkship receiving a lot of cues in the environment about ways that they stood out. So other staff members saying things like, they don't see a lot of people my color in this area, or patients fixating on someone's identity and asking where they're from, and what their name means, what their background is. And students really describing that they felt this lack of representation really negatively affected them. So one student said, if I notice that I'm one of the few people of my race or ethnicity, I start feeling self-conscious about myself and how I present to others. And for some students, the salience of race and ethnicity engendered an internal pressure to represent their group well, feeling compelled to work harder than other students, be more thorough than other students, and burdened not only to showcase their own capabilities, but to combat bias around that. The other major area was around past experiences. So this is something where there might not necessarily be a cue in the current environment or a trigger that's going on currently, but because there have been so much communication in the past around things, someone has a fear that this is going to come up and is kind of constantly monitoring. So one example of that was someone being told that they were only accepted because of affirmative action. And even if that wasn't being actively brought up in the learning environment or the clinical learning environment, it was still ever present while there of kind of that fear. And the last area is a very big one, which we'll discuss more in a bit, was witnessing microaggressions. And again, that could be either an experience of it or witnessing this, towards other learners, towards patients, between team members, but that being something that's present in the environment. And so when stereotype threat was activated by any of these triggers, then a process occurred internally within the learner. And it's important to understand that. So part of this had to do with power and power dynamics. So power dynamics featuring really prominently with students perceiving themselves as both minorities and students, and therefore positioned at the bottom of the medical hierarchy. And that hierarchy really influenced students' decisions about how to respond from threats, particularly from supervisors and patients. And they often expected their supervisors to respond in their defense, and sometimes that didn't occur. The other large category is, trying to figure out how to juggle a response to, for example, a microaggression, while also juggling the pressure of assessment and grading, responsibilities for patient care and for learning. And after weighing all of this, many concluded it might be better not to say anything, and worried about the impact on their careers. And many described believing that these threats really detracted from their educational experience and performance by adding an extra load onto already taxing clerkships. So an example of this cited in the paper was a student saying, "It was so stressful to get these comments. Do I want to give an answer that's going to appease them and maintain a good relationship? It's a big loaded question when I'm trying to think of the differential diagnosis for altered mental status." So again, you can really see that cognitive load that's impacting the ability to just engage more purely with the learning around medical knowledge and patient care. And in terms of the emotional impact, the authors described this as being very apparent, with multiple students crying during the interviews, using very charged words like feeling shocked and dehumanized, isolated, disrespected, and singled out. So we wanted to review this study so that you could have a deeper understanding of the experiences of a number of our learners. This also applies to our work with patients and with colleagues and interprofessional colleagues, and the understanding of ourselves and identity. So we want to kind of take a step back now to think about some of the larger frameworks around this work, if you can keep some of these examples in mind. And I will pass this off now to my colleague, Dr. Hubbard.
Thank you so much, Dr. Hesser. So as was shared, we've talked a lot about the clinical environment and kind of learning and what can happen specifically to underrepresented minority trainees. And so now we want to shift our focus a little bit to talking about, clinical training and how these factors really kind of factor in to kind of how clinical care is provided and some of the considerations that we have as part of clinical care. And so this right here just kind of gives a kind of depiction of this kind of evolution that we are continuing on in terms of our understanding of how things, like bias, microaggressions, not only impact learners as we were just discussing, but also in the clinical context, thinking about ourselves as well as those that we work with. So I'm going to give some definitions of these concepts, but really that we've been on this progression from the idea of cultural competence or culturally competent care to a term called cultural humility. And then most recently, more language has discussed the idea of cultural or structural competence. So really kind of moving from somewhat more of an individual standpoint to more of a kind of broader societal structural standpoint as it applies to conceptualizations of care or things that can impact those in which ourselves and those who we care for. So I'm going to start with the idea of cultural competence. And these may be terms likely that you've heard before, but sometimes people will refer to it as KS or A, knowledge, skills, awareness. And so the idea here is when we talk about our cultural awareness and beliefs, it's really, as stated here, our ability to understand our own values and biases, so kind of the implicit biases that we may carry, and how these impact the perceptions that we may have of those of who we work, right? How we perceive them, how we then perceive their clinical issues, so how we've kind of formulated conceptualization and treatment plan, and then ultimately how we interact in the actual therapeutic environment or building that therapeutic relationship or alliance with whom we work. Cultural knowledge is really just referencing our understanding in terms of knowledge about different identities, different cultures, different worldviews, perspectives, belief systems, and expectations in terms of what that means for that relationship. And then lastly, skills. So this comes down to when we think about interventions and our approach to care, our ability to be adaptable and engage critically in thinking about things that we do that are culturally sensitive and relevant to the individual that we work with, rather than, kind of a more one size fits all approach. So when we talk about culturally competent care, this is kind of the standard of what this looks like. And again, it's kind of focused on who we are and how we are interacting. From this concept, we've moved to the concept of cultural humility. And here, it's really, instead of thinking specifically about what knowledge we may hold, what awareness we have, or kind of what skills we have, you can really think about it as that interpersonal stance. So like, how do you approach situations? And this particular approach is one that is open. There's curiosity, flexibility about this, in relation to who we are working with, how they present, what ideas, beliefs, experiences that they hold. So, again, it's kind of going beyond that knowledge, awareness, and skills. And through this, kind of this openness, through this curiosity, it really helps us to be able to better understand someone's worldview, right? If I come in and I have preconceptions about who this person is and what they're about, right, based on maybe some of those implicit biases that I hold, that's likely going to impact everything that I do moving forward. However, if I, choose to come into an environment with someone who I work and I want to remain open, curious, I'm going to, really ask questions rather than necessarily making assumptions. This is kind of part of what we're talking about with cultural humility. And the reason why that this is so important is that it's positively associated with therapeutic working alliance. And we know that this is one of the keys to care, that if the people that we're working with view our relationship with them as positive, they're more likely to want to come back and seek care. They're more likely to listen to us in terms of recommendations, treatment plan. And because of that, they're more likely to have more positive outcomes through treatment. So this is something that's really important for us to consider. And it doesn't take away this idea of cultural competence. We're really kind of building on, if we think about it, kind of as layers, we're building on this additional layer in perspective that we can carry. And then more recently, we've kind of shifted to this idea of structural competence. And so we talked a lot about the individual, right? Kind of doing that insight, that, awareness of the self. But a lot of work currently has thought about shifting more outwardly, right? So it's not necessarily about where I am. It's not necessarily about all of the individual kind of characteristics of the individual in front of me, but it's that even broader awareness, right? What are the institutional forces at play? What is going on in the environment? Where are we positioned geographically? All of these different things can have an impact on how any of us show up in an environment. And so that's the idea of structure. So thinking beyond the individual and thinking about what are those forces that likely have, an impact on health. And so this has been termed, the social, determinants of health. So for instance, thinking about, financial, economic concerns, things like housing instability, transportation, right? Any number of those things and many others can have an impact on an individual's treatment, right? If they don't have reliable transportation, it may make it hard for them to be able to show up to the appointment, right? Um, if they have unstable housing, potentially it may make it difficult for them to interact, being able to, communicate consistently, or you as a provider being able to share information with the patient. So when you really look at the broader context, there are so many different factors that can have an impact on someone beyond just their individual kind of constitution, experiences, etc. And so when we think about this in the context of our work, it's our ability to be able to discern this host of issues, defined clinically as symptoms, attitude, or diseases, and think about the downstream implications about decisions that are made regarding this individual's healthcare. So the additional examples you have here: food delivery systems, zoning laws, urban and rural infrastructures, medicalization, or even about the very definitions of illness and health. So this is a really important perspective to hold, because undoubtedly, no matter where we're positioned, where we're working, we work within a context, we work within a community, we work within institutions, and those things have impact. And our ability to take that into account above and beyond the symptoms that the individual has presented with, their experiences they have, their worldview that they bring. This is just an additional layer that's really going to help us to be able to provide better care. And even beyond that, to be able to serve as advocates. And so something important that's come out of this work is really the thoughts around advocacy in psychiatry, broadly in mental health professions generally, that we often see ourselves in the realm of treatment. And part of what we learn and gain from working with those who we serve is a broader understanding and awareness, and an ability to use our power to be able to impact change in a meaningful way. And so this is a concept that for some can feel uncomfortable. The thought of advocacy, oftentimes can bring pictures to mind of people, maybe protesting, and concerns about, is that really our place as providers? But one way that you can think about it is that if you are working with someone that is struggling with their transportation, how can you as a provider potentially advocate or help make sure there are resources to be able to better help that patient, but potentially a host of other patients who may be in a similar situation, and that allows them to be able to better engage in care and have better outcomes. So this is part of this evolution of mental health care and healthcare generally. That's really important as part of our work, to consider when we're in any environment, but especially in that clinical environment. And so with that, we want to talk a little bit more about kind of building on some of what we've talked about experiences of learners, foundation of clinical training, to really kind of bring it back to what we've talked about, some of those definitions, specifically thinking about bias, just looking a little bit deeper into that. And we're really moving towards a conversation about what we can do specifically in terms of combating this and raising our own awareness so that we can be better positioned to be in positions to help. And so with that, I'm going to pass it along to my colleague, Dr. Hua.
Part of what we're talking about, thank you, Dr. Herbert, for sharing around structural competence and thinking about ways in which we might hold individual biases. Our first step in terms of being able to have a better sense of what, as an institution and as a healthcare system, or as a larger organization, what we can do is to determine what are those blind spots. In order to determine those blind spots, we have to think about where our biases lie. We also know that our biases contribute in the way that blind spots do in terms of increasing the rate in which we might have microaggressions. And these microaggressions occurring at individual levels, but they can also occur at these larger systemic levels. So really important to dive into what our blind spots are and what are some ways in which we can learn more about what those blind spots are and the impact it has on others, particularly in the communities that we serve. So let's take a step back here. Dr. Hassard provided some definitions of types of biases earlier. We're going to dive into that a little bit more and then go into how we might go about identifying them as well as the impact. So first, explicit versus implicit bias. Explicit bias is the biases that are really easily seen. We might all know individually that we have certain biases or impressions or stereotypes or attitudes towards people. And these are biases that we're actively aware of. We might not try to think about them, but we are aware that it's a bias that exists. So this might be knowing that you have a bias or a stereotype of an individual or a community of individuals. What we're really more focused on today and what we want to examine is these implicit biases. And the reason for that is that these implicit biases are often unintentional, are often unconscious, and are automatic. And by not being aware of them, basically we're continuing to commit microaggressions on individual and larger systemic levels. So without knowing that these biases are being enacted, we're not able to have an impact on the influence or the negative influence it can have on others. Something that a supervisor of mine shared with me a long time ago in my graduate training that really stuck with me can be used as a tool in some ways to think about how we might work to identify some of these biases. This tool that he gave me was more about observations of my work as a psychotherapist, and particularly in training. And what he shared with me is this saying that if it happens one time, it's an incident. If it happens twice, perhaps it's a coincidence. If it happens 3 times or more, it might be a pattern. And I think it really helped me in my work as a psychotherapist and thinking about what are the things that I might be doing in my work with my clients, perhaps unintentionally, that may actually be a pattern of mine. So I think it's a helpful way to kind of examine, are there these implicit biases that we hold as healthcare providers that we might be enacting in the work that we're doing. An example that I'm willing to share from my own work is that I have a large number of trainees that work with me. And in my first 3 years as a psychologist at the VA, I took on one student who was a graduate student every year. We'd go through the selection process and the interview process and then make our selections. After my 3rd year of selecting a student, I realized that all 3 students from that first 3 years of taking on a graduate student were from the same program. Now, although we had students across many different programs applying to work in my rotation, all 3 in those first 3 years were from the same graduate program. So this might be an example of an implicit bias that I had. I certainly wasn't going about reading through their CVs and their essays and their applications thinking to myself, I'm only going to take students from this one school. In fact, I can share that I did not do that. But upon reflection on my actual selection practices, there's a potential blind spot here. There may be something about that graduate program or my perceptions of other graduate programs that made me give greater looks or an examination on students in that particular program. So this is an example of an implicit bias. It wasn't in my active awareness. It wasn't intentional, but it's clear that there was a bit of a pattern here. And so one way to self-correct was to pay greater attention to that and think through ways in which I did my selection processes so that I can minimize the impact of that bias. We also know that there's levels of bias, levels of discrimination within implicit bias. The first that we'll talk about is personally mediated, or might be referred to as individual or interpersonal. As it sounds, these are individual acts of bias that may be enacted from one person to the next. This might be from me to a trainee or me to a colleague, perhaps amongst individuals within a healthcare system working together. And as we mentioned, oftentimes these can be overt or even subtle. We may not be aware that we're doing them. We may not be aware that it's happening. We also want to examine times in which, as Dr. Hubbard discussed earlier with structural competence, we want to think about ways in which there may be institutional or structural discrimination or biases. These would be things such as unfair policies or practices or procedures that institutions have that produce routinely inequitable outcomes based on identity or intersections of identities. Examples of this might be the ways in which we have family leave policies, or who gets funded for grants, who gets compensated more, who gets higher promotions, or who's more likely to have a promotion. Something in the field that I work with in psychology, it might be that in a particular organization, there may be more individuals who identify as women in a particular section of psychologists. But when you look at who's being hired as managers, who's being promoted, is there a disparity there? So there may be these other levels of institutional discrimination and biases that are in place. We might see and think that we have a diverse diversity and inclusivity in who we hire, but then within those who we hire, are they being promoted or compensated fairly and routinely across the board? So we want to look at these levels, just like we wanted to think about not just these individual interactions and these individual biases and blind spots, but the larger institutional and structural ones. Why does this matter? We know that bias does have an impact on individuals. And one example that we'll focus on right now is ways in which it shows up in letters of recommendations and evaluations. These are in the letters of recommendations that we might make for trainees that work with us, and evaluations that we have that are required in order for them to complete their work. Several examples that can be seen, including some that are listed here. One study, more negative reviews of women physicians compared to male physicians. And another example, letters of recommendations for men were longer in terms of the length of the recommendation and had more standout adjectives. One that we can go into a little bit more is involving that last study where over 87,000 evaluations were reviewed. These are clerkship evaluations for women and UIM, so that's underrepresented in medicine students. Oftentimes the students who are underrepresented in medicine oftentimes come from our BIPOC communities or Black, Indigenous communities and people of color communities. So in that particular study, it examined the adjectives that were used to describe the applicants or the folks who were completing these clerkship evaluations. And as mentioned, over 87,000 evaluations were reviewed. They found that there were some differences related to gender and related to identities, individuals who were part of the underrepresented in medicine identities. So in terms of gender differences, there were greater use of more personal attributes, such as the word lovely for women who were in these clerkships, as compared to words such as scientific that were used more often for men. Noticing that words such as lovely kind of characterize more personal attributes, whereas scientific is more competency-based. When you're talking about a clerkship or internship or some kind of residency program, these types of descriptors do influence the ways in which we perceive the applicant and the candidate. In that same study, they found differences related to between those who are underrepresented in medicine also were more likely to have personal attributes described of them, such as the word pleasant, versus more competency-based attributes for those who are not underrepresented in medicine, such as the word knowledgeable. So again, these can be subtle. It may not be that these individuals who are writing these letters of recommendation or evaluations are thinking to themselves, oh, I purposely want to use these more personal attributes or adjectives for this group of people or for this individual, and I'd rather use more competency-based words for this other individual. It's just that these are happening at subconscious or unintentional levels. So we have to find ways to make them more conscious, finding ways that we can better identify when we do this and why. Because the reality is that we all have biases, and part of it is that it's really hard to talk about. If we think about talking about our biases and blind spots, I know that what comes up for me is that it can feel uncomfortable, or I can worry that if I talk about my biases, others might judge me or think that I'm being discriminatory. Or perhaps that I worry that I don't want others to feel uncomfortable. Part of it too is that discomfort makes it to where we oftentimes avoid these discussions, but the avoidance of these discussions actually leads to greater use of these biases. And if they remain unchecked, they really can influence a whole host of things, such as our interpersonal interactions and dynamics. It can make us have more biased decision-making. This is where our stereotypes and assumptions of people or groups of people may lead us to making decisions that are more systemically biased. And they also, unfortunately, increase our use of unintentional microaggressions in ways that we'll discuss more later in this presentation. Here are some more specific examples of how bias can impact healthcare. We know that, as discussed, bias can impact our interpersonal interactions, but also including our interactions with patients. This means that the way which we talk with our patients and our work with them may influence whether they can be, whether they're going to be adherent to recommendations including the medications or the follow-up appointments or the work with interdisciplinary care teams. We also know that it may influence treatment follow-up and increase treatment dropout. Patients who have these interpersonal interactions that stem from biases also may perceive their care being of less quality. We also know that bias can impact internal dynamics. So that's between two staff members, or perhaps staff and a supervisor, or among supervisors, or perhaps within members of the system across a larger healthcare system. And of course, we also know that it impacts costs in terms of waste of money and time. We know that for patients who have who perceive biases and have less quality healthcare outcomes, of course, that's going to cost the healthcare system more money, and our focus on providing quality care, which is always our number one focus, is also going to be impacted. So we know that bias impacts our interactions on an individual level. We know that impacts our work as providers. We know that it impacts larger systems, and that it can have a whole host and range of influences that we can really hope to examine more so that we can decrease its negative impact. This goes back to the danger of a single story that was shared earlier. This is a really wonderful, brilliant TED Talk by Chimamanda Ngozi Adichie that we highly recommend folks watching. It's widely available on YouTube if you just type in the danger of a single story. And this goes back to, there are these narratives that we have, stereotypes that we hold, and we all have them. And in the talk, she talks about how these stories are not necessarily untrue, but that they are incomplete. They are not holistic, they're not comprehensive. And in having these singular stories, we may unintentionally continue to suppress and oppress communities in which we serve and operate in. She shares about her own experiences of having folks have a singular story of her, as well as experiences where she's had singular stories of others, and finding ways that we can really approach that and identify that better. And that's what we really want to challenge you all and all of us here with us today about, to think about and take a moment and reflect. What is an example of a singular story that you have about a community that you serve and provide care for? Perhaps this is about an individual. What are some singular stories that you have about individuals that you work with and who you care for? We further want to ask you to reflect on, where did this story come from? Did this come from media, from your upbringing, the environment that you grew up in, the interactions that you have with others? the interactions that you have with people in your community. Further, what maintains this story? As you continue working with the communities in which you serve, what are the narratives that make it to where the story is hard to diffuse from? And then lastly, what other stories might better serve your patient or client communities? What are more comprehensive, holistic, and patient-affirming ways in which we can think through this? An example that comes to mind to me is I read this article by Masuzaka Knapp in 2019, and it talks about individuals who are dealing with addiction, and particularly individuals who are seen in residential treatment centers. I think it can be very easy for many of us to have singular stories about addiction. I certainly have my own, and those stories around addiction may come from all kinds of sources. What maintains those singular stories about addiction oftentimes involves that it might be a narrative that the individual did this to themselves, or that if they just stopped using, they could get over it, or they would live a better life. But part of what maintains these singular stories is that there are these systems of influence that really help to maintain and reinforce these oppressions. An example from the article talked about how BIPOC individuals, again, Black, Indigenous, and people of color communities, have less access to treatment, have less treatment completion, and this is in the residential treatment centers, and have less access to insurance. These are all individual systems, the treatment centers, the insurance companies, the communities in which the care is received in. And if at each of these spheres of influence, there are barriers to care and barriers to access, this really kind of paints the picture that it's not just this individual singular story, that this narrative that if folks could just get over their addiction, they'd be fine. There's a lot more barriers to that. And that's what we really want to encourage everyone to think about, ways in which these singular stories show up, and how do we identify them, and how do we do different. So here are just some examples of things we can do to dive into your potential biases. One example is one that you may have heard of, the implicit association task. This is a task that you can complete online for all kinds of different identity factors, and it helps you to potentially increase your awareness of implicit biases that are present and that can impact your work. It puts you through a series of tests and tasks, and it tries to examine what might be underneath your conscious awareness. An example of a IAT, or the implicit association task, is that while you might believe that women and men should be equally associated with science, but that you find your automatic associations show that you, like many others, associate men with science more than associating women with science. And that goes back to what we shared earlier about letters of recommendation and evaluations, more of the competency-based adjectives being used for men and more of the personally based adjectives being used for women. There's a little controversy perhaps with the IAT in terms of suggestions that the IAT doesn't actually change your behavior, and in that thinking about and knowing about what your biases are, concerned that maybe it actually locks you further into your biases and enactment of those. This is where we really challenge you all to take that into your own hands. Let the IAT or your understanding, IAT aside, it really isn't about the implicit association task. It's about identifying what those biases may be, but you dictate that it controls your behavior. Going back to the example I gave earlier, that when I discovered that I accepted 3 students 3 years in a row from the same graduate program, I chose to do something differently the next year. I'm not saying I did that perfectly, but I chose to let that understanding of a potential bias I have about that graduate program, let it change my behavior the following year. And I changed my practices as to what I reviewed and how I reviewed the applications I received. So really think about how you can control and change your behavior as it relates to a value of social equity and social justice. Would also love folks to have other ideas to kind of dive into, maybe review your past letters of reference now that you've heard that there may be biases that are uncovered in that. Review your past evaluations of the students and trainees that you work with. Review your selection practices. If you're a manager who does hiring and selection for training programs, review how you go about discussing applicants and candidates. Does it feel systemic? Does it feel there are institutional cultural ways of doing things that can be examined further? Of course, always consult with peers, colleagues, individuals and communities outside of your own, or other examples as well. Before we go into the next section, I'll pass on to my colleague, Dr. Hubbard, as she talks about microaggressions and provides more information about diving into these individual interactions.
Thank you so much, Dr. Hua, for that wonderful review. And one of the things that you talked about is part of it. What can be outcome of this is these biases that we hold leading to microaggressions. And so we want to talk a little bit more about this concept of microaggressions. And we're going to look at it from two different perspectives in terms of microaggressions that we might receive, as well as when we are in situations and when we witness microaggressions occurring to others. And so, up to this point, we've really provided this foundation of kind of understanding related to, experiences of learners and factors that can impact them, the evolution of clinical care. We've really looked into the idea of bias, the different ways it manifests, and the outcomes. And this is really kind of taking us to this next level where we're going to really talk about microaggressions, but we'll take it a step further to really think about some actionable steps that you can take based on this. And that will kind of lead us to the next kind of step of the training that we're providing you, and we have an opportunity to do some more of this work in real time. So that's kind of where we're moving now. And so this portion is really going to be looking at kind of a step-by-step guide in terms of how we can foster awareness and build tools for responding. So as we've discussed further, and our hope is that in continuing to provide you again with these definitions, that it's really going to help kind of solidify this for you. And so easier for you to recognize it in your environment. But as was mentioned before, we talk about microaggressions. These are things that are kind of everyday, commonplace. They can happen in a multitude of different ways. But these, again, intentional or intentional, basically actions, things that happen that communicate hostile, derogatory, or negative messages, particularly to historically stigmatized groups. One of the things that's so important about this is having an understanding that, as was referenced, we talked about earlier, the idea of micro. When people hear micro, they assume small. So it means that this experience that you had it's small, which then can equate sometimes for people to be, less than or meaningless. We talk about micro, we're not referencing that these are kind of small incidences that are occurring. Another way that you can think about it is comparing micro to macro, in the sense that microaggressions, these can be things oftentimes that can be happen interpersonally, one-on-one, or kind of smaller groups, versus when we talk about something on a macro level, that's more when we're thinking about broader kind of systemic, kind of institutional things that may happen. So that may help kind of frame how you think about microaggressions as not being micro, but really thinking about things happening on a more individual or group level. So let's talk a little bit about the different types of microaggressions, because as that definition provides, there's a lot of different ways in which this can manifest. And so those who have done this work have kind of taken this broader concept of microaggressions and even defined it even more specifically in terms of particular types. And so you'll see here the idea of micro assaults, micro assaults, micro insults, and micro invalidations. So this kind of breaks this down further to behaviors that may be a little bit more overt or intentional and than others. Micro insults being things such as, rude or insensitive comments directed at an identity or a status that someone may hold. Micro invalidations being attempts to negate or kind of argue away the experiences of those in marginalized, oppressed communities. So in terms of, some different forms in which this manifests, verbal is one that people may oftentimes be most familiar with when they think about microaggressions. And so, for instance, an example is saying, "You are so articulate." Now, someone might ask, "Oh, well, why might that be a microaggression?" Well, there is a perception, and we think, again, kind of going back to these, perception, the single story, right? These biases that we hold, that certain communities, particularly communities of color, and others, there's this perception of them potentially being less than in terms of things like intelligence. So it's when you're saying that this person is so articulate, it's almost as if this is a surprise, right? That you wouldn't expect that someone like them to be articulate, right? So it's just a way that this kind of manifests. Can also be physical. So if you think about this in a context of they're in a meeting, primarily male identified, and those who identify as males only providing eye contact to the other males in the space and not providing eye contact with anyone who does not identify as male in the space. Okay, and that's, when you think about it, that's a way of exclusion, right? I'm not going to look at you because you're not important to me, or you don't have something of value, or you don't have anything that you potentially could contribute to this discussion, right? These are some of the, you take a behavior, and these are some of kind of like the underlying messages that things like that can convey. And there's also ways that this happens symbolically. Sometimes people, beyond maybe some of the physical or verbal, sometimes for people can be even harder to notice. But I can give, an example of a Dove did a campaign, so the Dove body wash. And they had this campaign where they had these pictures. And in the first quadrant, you had someone who we would perceive to be African-American. They had a brown shirt on, and progressively you see this brown shirt come off. And eventually this individual changes into someone who we would assume is a white female. And so this kind of goes from brown to white. And so kind of an underlying message as part of this ad is that, brown is dirty, black is bad. You need to use our product so you can kind of take away, kind of take off, that blackness in which is bad. And so this is, that's something that's in, that's in the media. It's not even, a direct interaction with a particular individual. But whether you're aware of it or not, seeing something like that can have an impact, right? You may not be aware of it. You may not be looking and saying, okay, so black person transforms into the white person, black is bad, white is good. But these messages subtly kind of get downloaded. And whether you recognize it or not, you may act or engage based on those beliefs. So this is some different types, and this is by no means an exhaustive list of all of the different types of examples of microaggressions that are out there. But this is, I think this is a good grounding in terms of thinking about different categories or what this looks like. So I wanted to provide, some additional, examples for you to review and consider. I kind of walked you through some examples in terms of why different things may be microaggressions. And really, as you're, kind of looking and reviewing this list, I want you to think about what is the underlying message that is being conveyed for every single one of these, right? Where are you from? What's the message that's being conveyed, right? I don't believe in race. Again, thinking about the message that's being conveyed. And so that can be really helpful in terms of taking sometimes a step back and looking and kind of critically evaluating a situation to have a better understanding of what's happening here, what message is being conveyed, and thinking about what's the potential impact of what's said, particularly in a context where we're witnessing a microaggression happening to someone else. You may even come up with your own, based on your own experiences through life. You may be able to add to this list with your own experiences. So I really encourage you, to really think about this for yourself and also what you've witnessed for others. The more you can engage in this type of exercise, it helps you to be more aware and attuned to when these things happen in the environment. So naturally, the next question to all of this is, once I have this understanding of what microaggressions are, and I know that they can happen in a multitude of different ways, naturally the next question is, well, what do I do if a microaggression happens? What do I do when someone says something to me, or I'm in a meeting and I'm feeling uncomfortable and I'm not quite sure why, but there's something there, right? So what I want to do now is kind of take you through kind of a decision kind of tree of sorts in terms of how you might think about this. I want to preface this by saying that this is one particular approach. Doesn't mean that this is the only approach or only way to go about it. And I also want to make note, when we talk about this, responding to microaggressions, that there are different ways to respond, and that the context is critically important to whether or not you choose to respond for yourself, or whether you choose to respond in a situation where others are present, right? Some of the things that you might consider are things such as power dynamics, right? Is this something involving your supervisor? Is this, a patient or client that you're working with? Is this a stranger on the street, right? Your response may be different in any of those situations. And that can be an appropriate response. So just want to, note that, because sometimes in going through this, we often feel like we want the prescriptive, okay, if X happens, then Y. And unfortunately, this is all a lot more nuanced than that. But I think these steps that we're going to go through does give you some structure in terms of how you might think about what your steps might be. So first step is we have to recognize whether a microaggression has occurred, and sometimes this is easier than others. As I said, sometimes it just may be a feeling of something didn't feel right there. Wow, I wonder why they said that to me, So sometimes, one of the things with microaggressions versus more overt acts of displays of, prejudice or discrimination towards others, is sometimes these things aren't always clearly known. So it's really important to really kind of be able to check in with yourself to kind of get a sense of what's happening in that moment. Step 2 would be, should I respond to this microaggression? And again, as I mentioned, we talked about the idea of context, right? Am I in a conversation with my supervisor? Am I with the patient, providing care to them at that time? Am I in the break room with my colleagues, right? All of these things are considerations that you may think about in terms of how you respond, either in that moment or potentially another moment at a later period of time. Our next step, thinking about how you want to respond, right? So once you've made a decision that you do in fact want to react in some ways to what happened, you want to consider, what are some of the ways that I could react to what has just happened? And responding in your chosen strategy. One of the ways to think about this in terms of responses, I'm going to kind of break this down into kind of 2 categories here. And the first category being ways that we might respond, we might call these adaptive strategies. And adaptive strategies, the way that you can understand it is sometimes there are things that we do for survival. And literally what I mean by that is getting through the moment, right? Getting through a difficult moment. And so when we think about some of these adaptive strategies, we might think about things such as choosing not to respond, so staying silent, right? Not engaging. This can also be engaging in behaviors kind of based on that, right? So someone who has an experience of potentially getting a lot of comments about how they're dressed, right, may choose to change how they dress moving forward, right? They may not directly confront, individuals, who may have made those comments. They may just choose to make a change themselves as basically a reaction to an experience that they've had. We kind of call that a personal change strategy. So that's adaptive, right? And it's about survival. It's about getting through a very difficult moment, right? And so that's kind of one perspective that we can have. Sometimes your response will be just that of no response. However, on the other side, we have something called generative strategies. And when we talk about generative, this is actually a situation where you will choose to respond. And there's a number of different ways in which you can respond, such as educating the individual. Sometimes it may, depending on your relationship with the individual, sometimes people may even choose humor. Like, wow, I didn't, take you as someone who would, X, Y, or Z, Again, context being very important here, but the key with generative strategies is that you are going to decide kind of what's a way that you can interact with them. Hey, you might not realize this, but when you said this thing, this could actually be perceived, in this way, and this is kind of how this, impacted me, right? So generative, so interacting with the individual or individuals that perpetrated the microaggression. Once you've decided to respond, in whatever way you've decided to respond, right? Whether you've chosen to stay silent or whether you chose to engage with someone in a conversation, like, hey, what did you mean when you said, X, Y, or Z? That I'm so articulate, right? Can you tell me what you meant by that? However you choose to respond, after you've engaged, reflect, how did it go? What worked well or didn't work well? And what do you need in that moment? Now, in mapping this out, this by no means indicates that simply by choosing not to respond or choosing to respond in a more overt way, that anything that you do is necessarily going to result in a positive outcome, right? because we can all think of probably experiences where someone's reacted to something and the other person becomes, very defensive or worse, right? So this by no means prevents that, but it's a way for you to be able to kind of think about what choice that you would like to make, and then consider what you might need. It might be connecting with a colleague, it might be reaching out with a friend, might be talking with your supervisor, whatever that is. It's really important to take care of yourself after an experience such as this, because it can be very painful, it can be very distressing. And so it's really important, to recognize that that's the truth of these types of experiences, and to be able to connect as you need for additional support. So this is some examples. I talked about the idea of adaptive versus generative, and I kind of started to give a few examples of what that looks like. This slide gives you some different types of kind of generative approaches to how you might respond, right? So, nonverbal cues is one, right? You might change, you might make a face, change the expression on your face. You might sigh, these are all different ways of communicating your reaction to something that's just happened. Sometimes it may be trying to get others, maybe it's a situation where others are around, to add their voice to the conversation, right? To be of support, or kind of diffuse, or kind of help you navigate. So I really encourage you to kind of look through these strategies and really think about, one, what is kind of your go-to approach, right? Do you tend to maybe not respond in situations? Or if you do respond, what sort of things do you do? Does it fall within any of these strategies? Do you recognize any of these things for yourself? And even, are there ways potentially that you would like to respond, that maybe this kind of gives some context, or structure to how you might do that, right? So really think and consider this for for yourself. So we've talked a lot about the idea of, what microaggressions are, what do we do when something like this happens to us? But we also have to talk about, what do we do when this happens to someone else, right? And that we're there, right? So you've likely heard about the word allyship, right? And have potentially a sense of what that means. And allyship is something that's very important. And if we kind of add to it, or maybe even kind of take it a step further, we're going to add this concept called being an upstander. And being an upstander is really someone who takes action, in this situation, in more of a direct way. So we're going to talk a little bit about what that looks like. So one of the things that's kind of come out of this work, in terms of thinking about how do we intervene when we've witnessed a microaggression occurring to someone else, one of the kind of skills that has been built around this is the idea of micro interventions. I know we have a lot of microaggressions. These are micro interventions. And so these are things that we can do really at all times. It doesn't necessarily have to be in direct relationship to witnessing something, but these are kind of the everyday words or deeds, things that we can do intentionally or unintentionally, that communicates to those who are targets of microaggressions that we validate their experience, that we value them as a person. We want to affirm their identity, whether it's a racial or ethnic group, or other categories of identities. That we support them and want to provide reassurance that they're not alone. So these are things that we can do that affirm these things. The goal of these micro interventions is we want to take something that can be an ambiguous situation and make it visible. They can be invisible, more visible, right? Kind of explaining, the dynamic. Being able to disarm the microaggression, being able to potentially educate the individual who's engaged in the microaggression, and knowing when and how to seek external support when we need to. So this is what this is really being able to, the primary goal of these interventions. This is why we engage in these micro interventions. So I'm going to share with you some examples, and there's a lot of examples here. So I encourage you to take some time and review this information because these are important considerations in terms of things that you might choose to do in an environment. And so this is a table that we have here that's split in two. And what you'll see here in these three different columns that kind of talks about things that are directed specifically towards the person who has engaged in the microaggression. We also, again, we can't forget, we talked about the individual, but we can't forget those institutional and societal ways that things manifest, right? So this can happen in a multitude kind of different levels. And again, it kind of gives some examples here of different things that you might consider depending on what the context is. So maybe, for instance, things like when we talk about making the invisible more visible, we might challenge the stereotype. We might name, hey, that is a stereotype and kind of challenge that, assumption. Disarming the microaggression. I'll give another example of this. So they talk about this just expressing disagreement. I don't believe that to be true. And that's not true. The evidence that I have indicates, X, Y, and Z. Maybe interrupting that individual. I'm gonna stop you right there. I have some concerns about where this conversation is going, and I'd like to, and kind of take it further. So that's just a couple examples, and I'm looking at the more individually kind of directed actions at an individual engaging. So look through this because there's a lot here in terms of considerations of things that you might do. The additional levels, educating the individual. So I've kind of done some of this, or I've kind of mixed some of these in how I've responded. Differentiating the idea between intent and impact. And this is huge, right? You may not have intended, to offend or be offensive. However, when you said X, I felt Y. And, that's really important. You might also choose sometimes to seek external interventions. This is what we kind of mentioned before. It's kind of knowing when you might need to bring others into a situation. And so that might be, many different ways. You might choose to report what's happened. You might choose to seek support, social support. So different ways to do this, So again, encourage you to review, encourage you to think about for yourself, what sort of things have you engaged in or not engaged in? And there's probably a lot of great ideas here for you to consider in terms of things you might choose to do in the future. So bringing it back again, I know I sometimes say things again and again because these things are really important to remember. So context matters, right? We have to think about, is what's happening right here, is taking action at the time, does it make sense? Is it safe to take action? What is the context that I'm actually in? Am I in a treatment room? Am I in a staff meeting? Am I in a meeting with a colleague, right? Adjusting your approach. How you choose to respond in one context might look different in another context. So kind of the adaptability here. Be attuned to the nature of the interpersonal dynamic and relationship here. And again, this is, I think, goes back to who am I interacting with? What is the broader context of this? If I choose to respond, right, generatively, right, if I choose to engage, how does that impact my relationship with this person? For instance, how does this impact the care that I'm providing? How does this impact kind of our therapeutic alliance, right? These are all things that we have to consider. And we can always seek support, right? This is not a every time I respond or every way that I engage, things are going to happen perfectly. So a lot of compassion is really important to have in this process. Sometimes we're not able to react in the moment, or we choose to not respond in the moment, I should say. And we might come back later and say, you know what? You know, when we were talking yesterday and you said X, Y, or Z, I just want to talk with you a little bit about, you know, what came up for me as part of that. That's okay, right? And you can see how that may even happen in a therapeutic context. Remember when we were having this, you know, let's talk a little bit more, you know, about what happened there. Of course, now that we've kind of talked about, you know, if something happens to me, if something happens to someone else, of course, the fear is always, what happens if I commit a microaggression? Well, as we've already discussed, all of us are capable of holding prejudice, bias towards other groups of people, you know, experiences, worldviews. And so with that being said, any of us are capable of committing a microaggression, right? So it's really important to name and acknowledge that. You know, microaggressions aren't only something that certain people do. Any of us can do it. We've all done it, whether we are knowledgeable that it occurred or not. So what do we do? Well, one of the things that's really helpful is for us to name it. You know, you might say something and just take, oh, wow, I just realized what I just said to you. And I just want to take a moment to pause and just, you know, acknowledge, you know, what I said, right? Naming it is critically important. And remembering that intent is not the same as impact, right? So I may not have intended to be harmful, but I may have been harmful, right? And so it's more important that I think about how that other person's doing than necessarily the fact that I didn't intend to cause harm. And so when we do that, it's really helpful if we're really going to take the time to listen to the other person. You know, can you tell me a little bit more about what that was like for you when I said that? I really would like, you know, to know how that impacted, how that landed for you. And notice when you're becoming defensive, right? Because this is not a comfortable situation by any means, right? None of us want to think that we've done something that's potentially harmed someone in any way. But it's really important for us to be able to be present in that moment, allow that individual to share, be able to reflect back and validate what they said, and be willing to apologize when necessary, right? These things can go a long way to really creating an environment where people can feel more supported and safe, knowing that if this happens, we don't want it to happen, but if it does happen, we can engage with each other and we can find ways to move forward. So I really encourage you to think about that. And maybe even times when you might have committed a microaggression, think about what maybe you did, what maybe you didn't do, and what maybe you'll choose to do in the future if this were to happen again. So with that, we are going to talk a little bit more about, we've talked about identities here, and we're going to, expand on this a little bit more. And so I'm going to go ahead and pass it back to my colleague, Dr. Hua.
Thank you, Dr. Hubbard, for sharing with us about microaggressions and giving that really wonderful step-by-step around ways in which we can be an upstander. So next, we'll talk a little bit more about intersectionalities. When we talk about microaggressions, we want to be very careful that we're not just focusing on one type of microaggression, meaning that sometimes we might think about a race-based microaggression or one based on religion or spirituality or ableism or any kind of range of identity factors. But in intersectionality is this notion that all of these identities interact and intersect with one another, and they cannot be separated. They do influence our sense of self and how we operate and walk through this world. So these are axes of advantage or disadvantage, or perhaps areas of privilege or oppression that occur at individual and structural levels. An example I could give is I'm a cisgender male, and as a result of being a cisgender male, I'm never misgendered. I'm never having to worry about having access to restrooms that are available to me, for example. So that's a privilege I hold. However, as someone who is part of the LGBTQ community, as someone who is a person of color, I have experienced racism at individual and institutional levels. I've also experienced homophobia at individual institutional levels. So the intersectionalities piece is that I hold these privileges, for example, being a cisgender male, in ways that influence the way in which I operate and live in this world. But it intersects with these other identities that I hold. So we want to make sure that we think through that from an intersectional lens. So these are some examples of intersections of identities that may oftentimes go underrepresented. Could be in our healthcare systems or in the work that we do. By no means is this a comprehensive list, but are some examples of identities that we really want to think through ways in which our individual clinics and hospitals, the environment that we have our clients and the environment that we provide in training, are we providing inclusivity as it relates to things like body size and body shape, relationship status or relationship structure, caregiver status, veteran status, HIV status, biculturality and multiculturality, individuals who have multiple kind of racial backgrounds and identities and influences that influences the customs in which they participate in, gender identity, neurodiversity, chosen family dynamics, all kinds of things that may be underrepresented. And we really wanted to think through ways in which diversity, equity, and inclusion show up in the ways in which intersections of identities operate within ourselves and within our communities in which we serve. So here's one way we can do that. We can think of intersectionality and systems of privilege. And really, we would recommend that you map out some of these. You might choose a client that you're working with, or perhaps think through a community that you serve, or perhaps where you teach and where you operate. And as we gave the example earlier of how we can have a singular story of addiction, we can also have a singular story of all kinds of things. People from a certain community, people who live in a certain area, people from a certain neighborhood, people with a certain political affiliation. So when we think about it from these larger spheres of influence, that individual identity might go in the small circle here, or on the left example in the middle. But as we go further out into these spheres of influence, we want to consider all the ranges of intersections of identities that impact that person. So it might be this internal dimensions section here. But then what are the community dimensions and influences? The workplaces, the neighborhoods in which they live, the grocery stores they have access to. And then beyond that, what are the larger life experiences and domains and dimensions? And then of course, institutional, and of course, things like media, our economy, the policies that govern where we live. Does it allow folks to have inclusive access in ways that are equitable? So really encourage folks to think through, again, not just the individual identity characteristics, but what are these larger spheres of influence, and taking into account the intersections of identities. Are the ways in which we provide care and provide training doing that? And does it allow folks to feel included in that process? Here's another example of what you can do in creating your own version of this as well to apply intersectionality and systems of privilege. You might take this example and think about, in every domain or every sphere of influence, is this aspect of your program or your clinic or your system anti-oppressive, anti-racist, anti all the forms of oppression? So an example we might give is, let's say you're working with a Latinx trans individual. So that client being in this circle here, what are the home influences that support or do not support that individual? What about the larger community? Do they receive transphobic messages? Do they receive transphobic messages in their place of work? Have they experienced discrimination in their application processes or in their schools? in these larger institutions? What are the messages they receive about being a Latinx trans person by society? Do they feel represented in the media? So these are all things that can impact a person. And so, in ways that we can look at so that we don't go into that trap of having a singular story, that we're able to see our individuals in the communities in a larger context. And as Dr. Hubbard mentioned, context is so important. In our last segment, we're going to wrap up with Dr. Hasser sharing some additional recommendations and resources and thinking through how to look into this information further and additional recommendations.
Thank you, Dr. Hua, for reviewing intersectionality. So we've been reviewing many frameworks and definitions to be able to understand the complexity of interactions through the lens of diversity, equity, and inclusion, and also beginning to think of ways to intervene in bias. And during the workshop portion, we will be practicing that more and reviewing these concepts in a more interactive and in-depth way. But before leaving today, we wanted to just share a couple of additional thoughts about that. So these are two ideas to consider at your own institution. These are two ideas to consider at your own institution. Peer consultation groups and live observation with a peer. So in the consultation group, you would really want to have clear guidelines to allow people to share and seek consultation around complex issues, and really want this to be a regularly occurring format. And something that can be really important with this is really, bringing people together, understanding why people are coming to this setting, and having some structure around how this might be able to work, and being able to share vulnerability. So an example of this would be, okay, I'm going to bring a situation that happened with a learner. I'm going to bring a situation that happened in this staff meeting or with a patient. And I want to get input from everyone here about what happened or what might be the best way for me to respond, or some options for how I might be able to respond about this. Or let's say you made a choice about a way to respond or intervene, getting feedback, that reflection on what occurred and what you might be able to do differently. Or this could be a spot where you could bring ideas and thoughts about how to work around systemic and institutional changes in terms of thinking about things at that level, like evaluating selection processes, evaluating letters of recommendation, thinking about other policy changes, or messages and images that are given, and how that supports inclusivity. So these are a few ideas to be thinking about, whether you're bringing kind of a case consultation model or thinking more at the structural institutional policy level. Another option is really doing an live observation with a peer. Now, some of you may have done this sort of thing in the past, either for clinical skills verification sorts of interactions or feedback around teaching. And as you know, whenever there's live observation, you really want to be having a focus area, right? So if someone's observing your teaching, you want to say, can you please, give me feedback on how much I include everyone speaking versus only highlight the people who raise their hands first, right? Or how I, reviewed this one concept, I'm feeling kind of rusty on how I communicate that. So being specific, agreeing on an area of focus, and being able to get input on this, and then come up with kind of a plan, a goal that you're going to have around this. And again, with this situation, it's something where you're going to want to have some sense of connection, a sense of being able to share vulnerability and be able to grow and ask those questions of, what were the ways I might have had some potential bias in the talk I was giving, in the examples I was giving in the talk, in the way I was interacting with different learners, and really being able to highlight those blind spots that we have, because others can sometimes, by definition, see our blind spots better than we're able to. And I wanted to share about this, going back to the study that we were talking about earlier, that involved clerkship students. Because in addition to sort of highlighting the details of the experiences that the learners had around stereotype threat and the negative impact, they also talked about several helpful coping strategies that were used, many of which were some of the examples that Dr. Hubbard was sharing of ways that they were intervening, and choosing to respond around these situations. They also identified responses from supervisors that help to promote a sense of psychological safety and inclusion. And so these are a few of those examples. So, in a situation, for example, when a patient is saying something derogatory about a learner, like, oh, are you somebody who's actually going into medicine? You don't look like someone who would do that. When the supervisor sort of draws a line and says, this is a teaching hospital and student Dr. X is qualified to be here, and part of their job to be here is to be here on the treatment team, and really including them and bringing them into the team. The other would be something like reassuring patients, clarifying their role, that they're in good hands, that this isn't something, recognizing the patient's vulnerability in this situation as well, and what concerns they might have as someone who it has relatively little power in a situation. So providing the reassurance while also providing the assurance to the learner. Correcting misconceptions in the moment. So an example of this was, a resident correcting an intern about saying a misperception about something involving that external appearance of Latinx folks. And creating a teaching moment. So something, if something occurs in the environment, being able to say, hey, this is a commonly, understood misperception that XYZ is going on. Let's check that bias. Let's recognize that this is something that occurs and that can end up causing harm in our patient care. So turning something into a teachable moment both validates it and also is an area of growth for the entire team. And then reflecting afterward. And I really want to highlight this one because very often for a lot of people, we aren't necessarily present when something happens, or the context does not make sense for there to be an intervention in the moment. And we can still have an intervention after that occurs to say, hey, I saw that thing that occurred and we couldn't say anything because XYZ was going on with the patient, but let's check in about it now. That can be incredibly validating and really, really important for someone to recognize that, something was observed. And also just being able to kind of check in about how someone's doing and providing that extra care and support is very, very protective. And to finally wrap us up, I'm going to hand it back to Dr. Hua. Thank you.
So this is borrowed from our industrial organizational psychology and management education colleagues. I think I really love this tool. It's called the Stop, Start, Continue feedback mechanism. And it's a way to apply getting feedback from various individuals and larger systems of care in which you're providing the training or in which you're providing the care that you do. And so part of this is to examine what are the things that are going really well in your, let's say, supervisor and trainee relationship, but then also in your individual clinical care or perhaps the larger institutional or structural mechanisms. We've talked a lot about structural competence and structural layers in today's presentation. So really validate and reinforce and support all the things that are going really wonderfully. So it might be, what should we continue doing? We've been doing this for a while, let's continue that. We've been doing this in our supervisor trainee experience or communicating this way, let's continue doing that. We've been doing this thing in our clinic where we make sure that the wait room is very welcoming, let's continue doing that. The next thing is, what can you start doing? What are the things that you haven't done yet, but you've learned from others? Perhaps you learned something from today's presentation, you learned from your colleagues in your live observation idea that was given earlier, or you learned from some system of care or some seminar, and you want to support those ideas. What can you start doing in these spheres of influence individually and larger institutionally that will help to provide an equitable and inclusive learning environment and an equitable and inclusive patient interfacing environment? And then finally, what can you stop doing? This can oftentimes be a bit harder to think about. You might be doing something for a while now, but because you're learning about your blind spots and your biases, you recognize that maybe this approach is no longer serving you, or perhaps it never did. And importantly, is it serving the communities in which you're serving, or perhaps the training learning environment that you're hoping to emphasize? So using this feedback mechanism for yourself as well as the individuals you're interfacing with, and thinking through what each person responded with and what they answered with, and how can you take this and transform this into action? What are the changes that you want to implement based on what you want to stop doing, start doing, and continue doing? And I'll turn the floor over to Dr. Hubbard to take us home.
Thank you so much, Dr. Hua. So with the time that we have remaining with our presentation today, we've talked about a lot. And so this slide is really to just kind of synthesize everything that we talked about to hit the kind of the high points of our discussion today. And so we, first kind of started thinking about what are all the things that can impact learners, right? What are all the things that individuals bring that can have an impact on their experience, and how can we be mindful of that? We've also talked about the idea of what kind of approach we want to have to care, and what sort of things that we want to think about on the individual and structural levels. We spent a lot of time thinking about the concept of bias, how we all have bias, and how that can lead us to behaving in ways that can sometimes be harmful and hurtful to individuals, things such as microaggressions, right? And we talked a little bit about what we actually can do to kind of intervene if we witness this happening to others, and that we can't forget the fact that we all represent a multitude of different identities and experiences and belief systems, and that's intersectionality. And so we can't forget to think about that for ourselves and for others, and that there's a lot that we can get from connecting with our peers through consultation, through our supervisor, through creating different kind of teaching moments that can help kind of further our growth on this journey. And as we move, to the workshop, we're really going to have time to kind of put in action a lot of what we've shared as part of this. But these are some key things that you can kind of reflect on as you kind of think about what you want to take away from this presentation. And then lastly, we have some resources. So I want to share some different resources with you that you might consider. Some selected readings here, and these kind of touch on a few, and this is a very, kind of short list here of things that you might read, but just wanted to highlight a few articles as well as books that you might consider to kind of further the learning. So please do take the opportunity to look more into these. And then as well as some additional resources. So again, there's a number of different organizations and groups that are working on different aspects of this. And so there's a lot of ways for you to get involved if you want to be able to get involved more, or even be part of advocacy on different levels. So we encourage you to review these resources. And then lastly, here you will find that we have included our references for you to review the work that we have shared. And so with that, we really want to thank you for taking the time to review this presentation, and we look forward to engaging with you during the workshop when we can kind of build on the foundation that we've created here.